All right, everyone, welcome to another Department of Medicine Grand Rounds. As just a reminder for all of you, if questions come up during the talk, please feel free to put them in the Q&A box or in the chat, and I will keep an eye on that for our speaker. So feel free to use that for your questions throughout the talk. And on that note, I would love to introduce our speaker for the day. It is Dr. Chris Goss, who is a professor in the Division of Pulmonary and Critical Care and Sleep Medicine, as well as a professor in pediatrics, and the Associate Medical Director for the Cystic Fibrosis Therapeutics Development Network. So he is more than well equipped to give the talk today on cystic fibrosis. So in order to give him as much time as possible, I will happily hand over the virtual podium to Dr. Goss for our talk today. So thank you so much for being here.
Great. I want to thank you and the Department of Medicine for inviting me to speak. This comes at a particularly opportune time because there have been sort of really groundbreaking changes in cystic fibrosis in the last year and a half, and I want to sort of highlight some of those. But I also want to take you through the sort of some of the story of CF and also some of the roles that the University of Washington played, which were actually quite central. We are one of the world's leaders in pseudomodal biology, and we're one of the epicenters of clinical trials in cystic fibrosis. These are my disclosures. Again, I'll just highlight the pertinence. I've gotten salary and honoraria from Novartis for sitting as the DSMB chair. I've had grant and research support for Boehringer Ingelheim as part of a clinical trial. And I run a review panel for Gilead Sciences. So this is my outline. I'll be talking about the diagnosis and clinical features of CF, improvements to date, pulmonary exacerbation management. I highlight that because I've spent the last 10 years working on this particular problem in CF, and then a review of standard therapies in stable CF and some future opportunities. Well, why give a talk in CF in medical grand rounds? And this slide should really sort of support its presentation medical grand rounds. There are now more more adults with CF than children. And this is from the US CF Foundation's patient registry, published last year in 2019. We're about to get our next. And what it shows is in 2018, 45% of the population were pediatrics, and almost 55% were adults. And now adult clinics are continuing to grow every year, while pediatric clinics stay about stable. So CF, it's a genetic disease. It's autosomal recessive. It affects about 35,000 people in the United States and growing. And it occurs at about 1 in 3,200 live births. And it's caused by mutations in the cystic fibrosis transmembrane conductant regulator. And this is a channel that traffics in bicarbonate and chloride. And there are approximately now 2,000 mutations that have been identified in this gene, which are now routinely looked for in patients with CF. So I do want to present and start with a case. I want to start with the case of a man in his 70s who presented with a persistent wet cough over 5 years duration. The cough led to, he had daily sputum production. He had frequent episodes of worsening lung function, improving with antibiotics. He had no hemoptysis. He'd smoked for about 30 years, had about a 30-pack year history, but quit in 1989. And he actually had, important in his past medical history, he had diabetes and he had sinusitis. And the sinusitis was quite problematic. He had some lung function tests when he came to our clinic, and this is FEV1 was 1.42 liters, which is 44% are predicted, and FVC of just over 2 liters, 48% are predicted. And this is, I sort of scribed his flow volume loop, and what it shows is this nice scooping out of his expiratory flow loop, which really is consistent with airflow obstruction. He then had a CT scan of his chest, and this is just a single cut through his non-contrast CT of his lungs. And what you'll see here in the right upper lobe is these very large airways that often end in little areas of mucus plugging. There are little nodules everywhere, and it's fairly extensive. It's a little asymmetric, so there's a little worse on the right than the left. And this was predominantly upper lobe bronchiectasis. So we received a call about this case and referred them on our way to our clinic to get a sweat chloride at Seattle Children's Hospital. And why do we go there? They're an approved center by the CF Foundation, and there are only a handful of places in the state that have approved sweat chloride laboratory testing. And his laboratory test, his sweat chloride was 53, which is abnormally elevated. And we'll get a little more into the actual levels we look for. And then he had a negative workup for other etiologies of bronchiectasis. And he went on to have CFTR, or cystic fibrosis conductance regulator, transmembrane conductance regulator genotyping. And he had 2 mutations that were found. One was delta F is F508del, which is the most common mutation seen in 75% of patients. And he had another mutation, the L206W. And this is, I'll talk a little bit more about that. But this disease requires 2 mutations. It's a recessive disorder. And he was given a formal diagnosis of cystic fibrosis in his mid-70s. So what are the gene defects and how do we think of them? This is a graphic from a Lancet paper in 2016, which shows the different, on the very far left, we'll have a normal CFTR, which is CFTR DNA. It's encoded to a full-length CFTR RNA, then goes through the ER and creates a nascent protein, a CFTR protein, which then goes through, becomes a mature functional protein on the surface of the epithelial cell. And you can disrupt this system in many ways. You can have you can make no functional CFTR protein. In this case, an example of that is a stop mutation called G542X. And then here's the most common, the F508del mutation, which is a trafficking problem. So you make a full-length CFTR, but it's misfolded. And so protease destroy it, and it never makes it to the surface of the cell. And then another very important kind of mutation is one that actually causes defective channel regulation. So you actually make a full-length CFTR RNA, you make a protein, nascent protein, it goes to the surface, but it doesn't work. And this is G551D. This is one of the more common mutations seen in the Irish population. And then there are also problems where there's decreased channel conductance, meaning the channel is there, but it doesn't conduct chloride as much and bicarbonate as much as it should. And then there are 2 other categorizations, one reduced synthesis of CFTR and then decreased stability. So how do patients present with this disorder? It's really a multi-system clinical manifestations. It has the most important abnormality discovered in the 1960s, late 50s, early 60s, was that there was excessive salty skin and salt loss, so there's sweat glands. And that really sort of came to the diagnostic test of the sweat, measuring sweat chloride. The most prominent abnormality in CF patients is chronic airways infection, inflammation, respiratory failure, and bronchiectasis in the lungs. And the next most prominent is exocrine pancreas dysfunction. And that happens in greater than 60%. In adult populations, about 90% of our patients. And then CF-related diabetes. And again, you might note that this patient had diabetes. And then the reproductive system, congenital bilateral absence of vas deferens in almost all men with CF. And then distal intestinal obstruction syndrome, which is a syndrome of obstruction of the colon with tenacious, thick material that causes significant obstipation and can lead to surgical emergencies. And then liver disease, which is seen in about upwards of 40 to 60%, either cirrhosis or steatosis. And then back to this patient, chronic bacterial sinusitis, over 90% of the patients with nasal polyps in about a third. The proposed mechanism and pathogenesis of CF, and this is a very oversimplified model, but it's that you get deficient or defective CFTR that causes decreased chloride and bicarbonate secretion in the epithelium, decreased sodium absorption, bronchial obstruction, infection, inflammation, and then airway destruction in the inflammatory response. So this little graphic on the right here shows the thick mucus with bacteria within the mucus, and then inflammatory cells trying to fight off the bacteria, but unable to, and continuing to send cytokines to the airway, and the airway is eventually destroyed. There is a diagnostic algorithm, and this was published in 2017, refined, and this is all patients now with CF should have both sweat testing and genetic analysis. And to even take that further, all of our patients now go through whole genome sequencing of their CFTR gene. but patients need to have a clinical presentation. The vast majority are seen in newborn screening, so this has been nationwide since 2010. You can also present with signs and symptoms, so we get patients referred from GI clinic for episodic pancreatitis, which is a rare presentation of milder phenotypes. Also, we get referrals from fertility clinics and from our otolaryngologists because of severe sinus disease, and also based on family history. So patients undergo sweat testing, and their sweat is either greater than 60, which is diagnostic, 30 to 59, which our patient was, and then less than 29 is normal. Now, mine is 10, just as so CF is very unlikely when you have a normal sweat chloride. And then you go on, if your sweat is abnormal, you go on to genotyping, and then if you have two causative mutations, you have CF. Although this is the algorithm, everyone seems to get full whole genome sequencing now, and we've been doing this for about 10 years. Sweat testing is interesting. This test was developed in the 1950s. It is the gold standard for CF diagnosis, and it's now done with a very a nice device that uses capillary motion to draw up the sweat. But you have an anode and a cathode, and the anode then drives a charged pilocarpine through the skin, underneath the skin, and then it affects the sweat glands in the skin, and then you start to pool up sweat underneath the sensor. And then again, it gives this mild current. You don't feel it at all. And then again, I said if sweat chloride less than 30 is normal, 30 to 59 is borderline or possible CF as in our patient, and greater than and equal to 60 is diagnostic. So there have been a ton of improvements in survival and advancements in CF therapy over time. And this is a graph that I put together with the help of Dave Nicholls in Pediatrics. And it really shows sort of this, when I was born in 1962, this is a devastating disease. The median survival was less than 10 years of age. They had already had pancreatic enzymes and airway clearance, and they'd already started using anti-staphylococcal antibiotics. This Staph aureus was a deadly infection in these children. And then anti-pseudomonal antibiotics came into place because Pseudomonas tends to be the next in the series of serious lung infections that patients get. Then we have lung transplant. The first therapy, DNAs or RH recombinant DNAs, was developed in the mid through the 90s and approved, and then inhaled tobramycin, azithromycin, hypertonic saline, inhaled as Trinam. And then these four other drugs up here I'll list. I'll leave them alone, but these are the drugs that actually treat the primary defect. But you've seen that the survival continued to improve through this entire time. Between 2000 and 2010, we did an analysis that we published in the Annals of Internal Medicine that showed that for every year that passed, mortality decreased by 1.8% in this population. And that seems to have continued. The median survival is currently 47.4 years. That was estimated in 2018 by the CF Foundation. And it's improving even in advanced disease. And this is a paper which I really love. It's published by Kathy Ramos in our department in CHEST. And what she showed is actually old historic data suggests that when your lung function got to 30% or predicted, you had a median survival of 2 years and therefore should be referred for transplant. So in this graph, she shows the proportion of patients living without transplant and then time since your lung function fell below 30% or predicted. And what she found is that this time is now quite extended. It's 6.6 years when she did this analysis, and this is in 2013. And the confidence boundaries were 5.9 to 7 years. So it really has shown that in all spectrums of disease, survival is improving. But has it improved uniformly around the globe? And the answer is no. This is a study we published in 2017 looking at the differences and advances in survival and by country. And we compared the survival in Canada versus the US. These are two well-developed countries with well-integrated healthcare systems and clear CF clinics. And it turns out we noted a 10-year gap between the United States and Canada. So in blue is the Canadian survival. It was about the same through 2000, then started to divide at about 2005, and now is quite wide at 10 years. So Canadians with CF live 10 years on average longer than Americans with CF. Why might that be? It could be how they handle transplantation for CF, and Dr. Ramos is spending most of her time thinking about how we treat and manage transplantation CF, and are we doing the right things? Are we referring patients appropriately in an appropriate time frame? Could be different healthcare systems. The Canadian healthcare system provides universal healthcare to all patients with CF. And it could be early nutritional implementation in Canada. In Canada, they started just because of an observational study published in JAMA, they started, recognized that giving children with CF high-calorie diet was able to increase their height, improve their lung function, and improve their survival. And it came late to the United States. And there may be other clear reasons, just socio-demographic differences between the countries. But survival and lung function have improved markedly. And I didn't show you lung function data, but it's impressive. Every birth cohort over the years, every 5-year birth cohort has improved lung function. And I would argue that no other lung disease has seen such a dramatic improvement in outcome over time. So what are we doing right? Well, we have a very clear care model. So we have a CF center here, an adult CF center managed by and run by Dr. Moira Aiken. We give a lot of antibiotics. We're the bane of existence of our of antibiotic stewardship because antibiotics use and liberal use of antibiotics in this population, in this because they have chronic airway infections, seems to have improved outcome. And then we have aggressive nutrition support, and again, more antibiotics. So I want to shift a little bit to talk about pulmonary exacerbation. This is the thing that most of our house officers have encountered because one of us in the CF clinic calls up and says we need to admit a patient for a pulmonary exacerbation. And you might ask, what is an exacerbation? These are, there's no standardized criteria. The definitions have included change in symptoms, lung function measured by spirometry, in a circular argument, use of IV antibiotics. So just by virtue of the use of antibiotics, you must have an exacerbation. Change in weight, meaning loss of weight, and people can lose up to 10 pounds during these events. And change in chest X-ray, which is much less common. This reference is a review article I wrote in December of last year. I think it's a fairly comprehensive summary of exacerbation. So the current approach to treatment is we give IV antibiotics, and we use 2 to cover Pseudomonas for 2 weeks based on prior susceptibility patterns. And again, there's a lot of debate about this approach. There are very few studies to support its use of this approach to care. But we have a lot of intuitive data from caring for patients to suggest that this works. We do airway clearance every 4 hours while awake, nutritional support, hydration. We continue their chronic medications, and we monitor for drug toxicity, particularly aminoglycoside toxicity. And these toxicities include loss of high-frequency hearing and tinnitus, and then worse, which is a vestibular toxicity. So patients who suffer vestibular toxicity, who have dizziness, it is permanent, and they'll have to go through rehab to learn how to live with chronic dizziness and spinning. We also use prednisone if they have an asthmatic component. But the evidence, as I sort of hinted, is really weak for our management of pulmonary exacerbation. I was part of a systematic review and treatment of pulmonary exacerbation back in 2009, and data hasn't really changed that much since then. And in a review of numerous questions about how we manage this disorder, there were only 2 that received a grade of B. And that's to continue their chronic therapies during exacerbation and use airway clearance. The remainder got grades of C, D, or I. And this frustrated me to no end. I wanted to provide a more standardized and structured approach to management. So we started something called the Standardized Treatment of Pulmonary Exacerbation Studies. And I'm going to present here the STOP-2 study. Some of the house officers and attendings may recognize it because we were the, I think, 4th leading site enrolling patients in the country. And this is a study that I started with a guy named Patrick Flume at MUSC. And this is a large-scale treatment trial for the duration of antibiotics, IV antibiotics, based on initial response to therapy. So in this case, at the beginning of their exacerbation, a physician determined exacerbation at visit 1. Patients were enrolled and screened in. And then we followed them up at day 7 to 10 to see their response. And if they had a large increase in lung function, meaning over 8%, equal to 8%, or improvement in symptoms, they were then pushed into this, what we call early responder arm. And there we randomize patients to either stopping antibiotics at 10 days or continuing for 14 days, our standard duration. Then we followed everyone 2 weeks after the end of antibiotics to assess their endpoint. If you didn't have improvement in lung function and symptoms, we put you into a delayed responder treatment arm. And this is the first arm, the early responders, was a non-inferiority design. This is superiority design. So we said that the patients will be treated for 14 days or 21 days. And why 21 days? You don't see a lot of that here, but there are centers in the United States who believe that 21 days is the standard of treatment. And we had centers who would not participate in this study based on the fact that we were randomizing to potentially shorter duration of therapy. And this study had 61 centers in the US and Canada. And I wanted to show you some of the results. Again, these were just presented about 6 weeks ago. The actual antibiotic duration in our early responders, we achieved what we wanted to achieve. This is a non-blinded study. So this is 10 versus 14 days. So the blue bar shows patients who were randomized to 10 days, or 134 of them. And the yellow bars are the normal 14-day course, and 130 were randomized to those. We had a mean day of 13.9. We had 5% withdrawals compared to 4% withdrawals in the 10-day. So what happened in this arm? So here is the mean lung function in percent predicted on the y-axis with 95% confidence intervals and days from start of IV antibiotics. So right here in white is the group that got 14 days, and in orange were the ones that got 10 days. And what you see is at the end of 10 days, the orange had a lung function improvement almost 13%, and the white had improvement at just over 13%. This is a per protocol analysis, which is appropriate for non-inferiority design. And based on our non-inferiority margin, these were deemed to be non-inferior. So 10 days was non-inferior to 14. Now, we also had the non-robust responders, and in that group, we compared 14 to 21. And this is a larger population. This is more of the exacerbations. So here in yellow were those assigned to 14 days. And then in 21 days, you can see a little broader. We had a broader windows because of just the challenges to enrolling someone to 21 days of antibiotics. So we had wider windows. But again, we separated really nicely the two groups. And the mean duration in the 14-day was 14.8. The mean duration in the 21-day was 19.9. And we had slightly more withdrawals in the longer duration treatment arm. So what happened in this arm of this part of the study? Well, absolute lung function changed from start of IV antibiotics to 2 weeks after. And again, here we have in white is our normal 14-day course. In orange is our 21-day course. And what you see is the lung function effect 2 weeks after the end of antibiotics is essentially the same. We did a ton of sensitivity analyses to show that both the robust responder trial and the non-robust responder trials, the results did not change with our sensitivity analyses. So I wanted to talk about the review of standard therapies, because although exacerbation takes a lot of my time, CF is primarily an outpatient disease, and we do a lot of management with their standard therapies. And I show this again just to remind you, we've added a lot to our armamentarium over time, and I wanted to just highlight a couple of the therapies. So we use our main chronic therapies, and then I call these mutation agnostic therapies, are mucolytics, which is recombinant human DNAs, hypertonic saline, inhaled mannitol, bronchodilators with beta agonists, anti-infectives, and inhaled tropomycin is one I'll highlight, but inhaled as Trinam, and then pulmonary exacerbation treatment. And then anti-inflammatories, ibuprofen. I'll talk mostly about azithromycin. I won't really talk about inhaled steroids or systemic steroids, which have all been used. I do want to talk about recombinant human DNAs. It was approved by the FDA in 1993. And the reason I want to talk about it is because the first human to ever receive recombinant human DNAs was here at the University of Washington under the careful guidance of Dr. Moira Aitken. And her 1992 JAMA paper was the early proof of principle that the use of DNAs could actually improve lung function. And here's the phase 3 trial that drove the FDA approval. By Fuchs et al. In the New England Journal. So patients started on either 2.5 milligrams a day nebulized or 2.5 twice a day, and either in light green or dark green. Their lung function went up about 8% and then stayed higher than placebo for the whole treatment duration, which was 24 weeks. It's important to know that that drug also reduced exacerbations. The next big revolution in treatment was inhaled tropomycin, which improves lung function. It was FDA approved in 1998, and it also had its origins here at the University of Washington. Arnie Smith and Bonnie Ramsey took IV preparations of tobramycin and did early studies to show that you could balance the pH and osmolality and then nebulize it into CF patients who were infected with Pseudomonas, and it would improve their symptoms and lung function. And this is the main trial that drove the approval of this drug. So patients were put on inhaled tobramycin at 300 milligrams nebulized twice a day compared to placebo, and they had 1 month on, 1 month off. And so the on months are noted in the orange bars, and the off months are noted without the orange bars. And on the y-axis is the relative mean change in FEV1, and the x-axis is time in weeks. And again, we show the confidence boundaries around those. But it showed that inhaled tobramycin improved the lung function substantially, and it stayed elevated. This is a large trial. Over 500 patients were in this trial. Well, after the approval of tobramycin, there were a number of important studies of the use of tobramycin, how you could use it in CF care. And this one I do want to highlight. It was in children, and it's called the EPIC trial. And the EPIC trial was a trial of inhaled tobramycin plus or minus ciprofloxacin for new Pseudomonas infection in children. And it was a four-armed, it was basically a trial where there were 4 different interventions. Patients were either cycled or culture-based therapy. So culture-based, if they were positive, they got another course of inhaled tobramycin. Otherwise, they just received it every 28 days. So what they found, though, is that the proportion of Pseudomonas positive patients in all arms was less than 20. So they had seemingly eradicated Pseudomonas from a vast majority of the patients. But what you can conclude from this, although it's not a non-inferiority study, is less was more. So this actually now is our common treatment. We treat based on if someone has new Pseudomonas, we give them inhaled tobramycin without ciprofloxacin. We give them for 28 days, and we repeat their culture. And the majority of those patients will be culture negative. And we apply this to adult CF care, even though there are no studies in adult CF care. I want to take a step back and talk about another mucolytic that we use commonly, and you'll see this on the wards, and that is hypertonic saline. And this is the Australian hypertonic saline trial, published in 2006. It was noted by a number of CF providers in Australia that their CF patients who surfed were doing better than others. And so the hypothesis was that you could actually add salt to the airway and hydrate it, and that would actually relieve some of the mucus obstruction that they get. You have to note that there's probably a clear indication bias. Those who surf are probably doing better than those who don't surf. But what they did is they compared 7% hypertonic saline, which is incredibly salty, and it was masked with quinine, and normal saline, which also masked with quinine. And they gave this 4 milliliters nebulized twice a day. There were 16 centers, 164 patients, equally divided, and they followed them for a year, but you had to have lung function over 40% of predicted, and it was both children and adults. And what did they find? They found that lung function in the hypertonic saline group went up about 2 to 4%, 4% and stayed elevated above normal saline. Their primary endpoint right here was the difference between hypertonic saline and normal saline. They failed to meet that. Although an analysis of the area under the curve, it was found that actually hypertonic saline patients had better lung function on average over time. It was also important in this study that exacerbations actually fell about 14% over a 12-month period. This therapy is very cheap, it's easy to give, and for that reason, it was widely adopted even though the primary endpoint was missed in the trial. Now, I want to switch gears and talk about anti-inflammatories. And the anti-inflammatory I want to focus on is azithromycin. Azithromycin had been used in a disease called Japanese pen bronchiolitis, and these are patients commonly infected with Pseudomonas. And then early on, in the late 1990s, early 2000s, people started thinking about it to be used in CF. And this is a study we ran called, to test whether azithromycin improved lung function and reduced exacerbations in CF. So we took patients with CF, adults and children, who were infected with Pseudomonas, and we put them on placebo or azithromycin. Azithromycin was 500 milligrams 3 times a week. What we found is there was a statistically significant improvement in lung function at 160 days, and the exacerbation rate fell by 40%. So at this time, azithromycin started to be widely used in CF in those patients infected with Pseudomonas. Now, more recently, we've come to wonder if there are some downsides to this drug. Azithromycin, it turns out, may interfere with tobramycin's activity in Pseudomonas. So there's some great in vitro data that really supports an interaction via upregulation of antibiotic resistance through this MEX-XY efflux pump. And this was published by Dr. Dave Nicholls. He's in the Department of Pediatrics here at the University of Washington. And what he showed is that untreated, these are clinical isolates of Pseudomonas on this graph here. They're at a log almost 10 to the 8th. When they were given tobramycin, they had almost a 3 log fold drop. When tobramycin was added, when azithromycin was added to tobramycin, it actually antagonized the effect of tobramycin. Azithromycin alone had a small effect. So he also went on with a number of others to publish some important clinical data saying that there may be some suggestion that azithromycin actually negates the effect of inhaled tobramycin on CF patients because of this phenomena that he found in his lab. So that led to a study to assess whether azithromycin did indeed interfere with tobramycin activity. He conducted a double-blind, placebo-controlled trial, a randomized controlled trial of azithromycin thrice weekly versus placebo in something called the TEACH trial. And this trial involved a 2-week run-in of azithromycin or placebo prior to starting a normal tobramycin cycle. And the results were very interesting. This was just presented 6 weeks ago. The results showed that azithromycin blunted the micro effect, meaning quantitative cultures went down less in the group who got azithromycin compared to those who got placebo plus tobramycin. But it really had no effect on lung function. It's unclear if it would have been a larger effect had it been more time. But it's an interesting phenomena. So we wait to figure out how to think about these two drugs together, but it really is important. We've just been adding drugs one on top of the other with not necessarily trying to assess whether they interacted. So what about novel therapies? And I do want to spend some real time here because this has been the sea change in CF. There's a whole era of new, what we term CFTR modulator drugs. And these drugs really start to address the basic defect. And there have now been 4 approved in the United States. Ivacafter, Lumacafter and Ivacafter, Tezacafter and Ivacafter, and Alexacafter, Tezacafter, and Ivacafter. There's a long mouthful there, but I'll talk a little bit more about what they are. Ivacafter is a drug that seems to turn on CFTR that's dysfunctional. It started in treatment of primarily G551D patients, and it showed that you could actually, and I'll show you the data, could improve lung function and marker of chloride or CFTR function. It was then expanded to patients who had this other defect, these decreased channel conductance. So this drug can attach to CFTR and seem to open its channel. Then came the next breakthroughs, which were this drug Orkambi. I'll use the primary names just for simplicity: Symdeko and Trikafta. And these are all patients. These 3 different drugs all started with patients with F508del mutations, decreased trafficking. And the 2 first drugs were only tried in patients who had 2 of those. The last drug, this Trikafta, was tried in patients who had at least 1 and a minimal function for the other, or 2 the same. So here's the study of patients who had Ivacafter for G551D, and it looked at absolute change in lung function. So what happened when you started this drug, their lung function popped up by about 10% and stayed elevated during the entire time compared to placebo. And this was a marked effect. And it wasn't just lung function improved. Their symptoms got better, and they stopped having exacerbations. It was remarkable. Dr. Aiken was our site PI for this study, and it was hard. It was a blinded study, but it was too obvious to the patients and the providers that the patients had indeed gotten drug. And more importantly, what they showed is this amazing biomarker response. Sweat chloride dropped almost 45 points. And this is within 15 days of starting the drug. And it stayed down for the entire period of drug treatment. So They showed that you could increase CFTR function by lowering sweat chloride. Abnormally high sweat chloride is a sign of CFTR dysfunction, and that was directly correlated with improvement in lung function and actually decrease in exacerbations. And I'm going to skip over the two intermediate drugs and really talk about the drug that was approved last November of 2019. And this drug got breakthrough designation by the FDA. This is the Ivacafter, Tezacafter, Ivacafter. And this is the study they used. This is the effect on lung function for patients who had two del F508 mutations, so F508 homozygous patients. And what they did is they compared it to the prior drug that these patients had been on, and showed a rapid, immediate improvement in lung function by about 10% by 4 weeks. And also, it actually decreased sweat chloride again by 45 points, which was very meaningful. And then they actually had a separate study to look at patients with just one del F508 mutation and a minimal function other mutation. And what this showed is their lung function, they were not on an existing drug. There were no CFTR modulators for this patient population. And their lung function bumped up by about 14%, and their exacerbations decreased by 63%. Really remarkable response. And again, these two studies right now, because of their the newest FDA indication, which is that you have at least one del F508 mutation is the current indication, now can be used along with Ivacafter alone in almost 90% of our patient population. So what happened when this drug rolled out? It rolled out last year in about November. It was rapidly taken up. So this is data I got from the CF Foundation. They have a very large and comprehensive patient registry that started in 1966. And all of our care sites enter data in real time after they see a patient to the registry. And so what they looked at is the number of exacerbations in the entire population in the United States divided by those eligible for the drug, 12 and older, and those 11 and younger. And so what you see is that there were about there were about on average monthly 1,500 patients with exacerbations every month. When exacerbations, when we started to see what happened after the drug was introduced, exacerbation rates in all of our centers fell dramatically. Now, this also was superimposed by the onset of COVID-19. And obviously, COVID-19 patients were then isolating, and they may have reduced their respiratory virus infection rate, which indeed could reduce exacerbation rate. But this was remarkable. We went from having patients in our hospital at all times to having almost no CF admissions at the University of Washington. And this was echoed around the country at major centers like the University of Colorado, University of Pittsburgh, Johns Hopkins. They had the same phenomena. So I want to talk a little bit about future opportunities to really sort of finish off this talk, because I think although these changes have been very dramatic and very exciting for us who work in CF, I think there's still a lot to be learned in CF. And the first I want to talk about is this personalized medicine approach, the use of epithelial cells, either rectal or nasal, to test CFTR medications. And we're doing this primarily in patients who are not candidates for these existing drugs. So this is courtesy of John Brewington and his team at the Cincinnati Children's Hospital and Medical Center. And so what they have is a program, the CF Foundation has set up a program where we have 6 centers around the country where we can send nasal epithelial cells, express mail, to their center, and they will grow them up and then test them, create organoids and create epithelial sheets of epithelials and test them with existing drugs. So this is an example of one of the patients. These are organoids or little sort of balls of epithelial cells. And when you give them CFTR activation, they swell. And that degree of swelling can be measured and quantitated and actually can relate to the increase in function of CFTR. This is just a photomicrograph and immunohistochemistry of one of their organoids that they've grown up, and just a really detailed and beautiful cellular collection. And again, we are now doing this with our patients. So we have done about 6 patients who have not been eligible for this drug. And then those that have responded in this way have been able to get them drug and then test their response. There's also some very exciting work going on in animal models. And the animal model I want to highlight is this little character up here, a ferret. So there are many animal models of CF, but I want to focus on the ferret. This ferret was developed at the CF ferret was developed at the University of Iowa. And so what they did is they created G551D newborn mice. So they have newborn ferrets. I mean, so they have knockout ferrets, untreated G551D knockout ferrets, and untreated homozygous G551D ferrets. And they all have a very distinct CF phenotype. Their pancreases don't work, and they don't work when the little baby ferrets are born. And so what they did is they treated these ferrets, the homozygous pregnant mother ferrets, with Ivacafter. And then what they demonstrated is that they could prevent pancreatic exocrine destruction and fibrosis, which has been a hallmark of the disease. And what they could also show is if they remove the Ivacafter, they reverse the phenotype, and the little ferrets got CF again. And this was published in Science Translational Medicine in March of 2009. And it's a very exciting work. There's also some exciting work based on studies of children who have gotten Ivacafter. And my colleague over at Seattle Children's Hospital, Margaret Rosenfeld, a pediatric pulmonologist, is the lead on a study of small children ages 12 to 24 who got Ivacafter. This drug has been approved sequentially. Now it's approved down to 2 months of age. And what they did is they studied Ivacafter, and what it showed is even in these children who we normally assume have lost pancreatic function for the rest of their life, even by the age of 12 months, had an increase of a marker called fecal elastase 1. Now, fecal elastase 1 falls dramatically with pancreatic dysfunction and loss of pancreas. And usually we see fecal elastase levels less than 100 in all of our CF patients who have pancreatic insufficiency. In this case, the fecal elastase levels have actually started to rise in these children, suggesting that giving these drugs early could rescue their pancreases and not lead them to a lifelong pancreatic dysfunction, which is an important challenge for the disease. There's also some very exciting data that I want to share with you, and this is courtesy of Pradeep Singh and Dave Nicholls here at the University of Washington. There's a very large study we call PROMISE. It's a prospective study to evaluate biological and clinical effects of significant correction of CFTR function. And this study is funded by the CF Foundation. It's 490 patients, and it started just as this Trikafta was being rolled out. And the idea was to try to understand how this drug affected all manifestations of the disease that the company would not be interested in. In this case, we are the epicenter of the microbiology portion of the study. And what they've shown in early response, and these are graphs of colony-forming units of Pseudomonas in the sputum, or bacteria in the sputum, in this case, Pseudomonas, on the patients that have received this new drug. And so some of them have not much change in lung function, in quantitative cultures, but many have dramatic changes in quantitative cultures of Pseudomonas in their sputum. And then incredibly unusually, a whole bunch of them didn't have any Pseudomonas. Now, in adult CF clinics, we consider Pseudomonas as a perpetual infection. In fact, we have a patient here we call patient 1 who was studied with data studying the evolution of Pseudomonas. His first organism he acquired when he was 1 year old or 2 years old, and it's the same organism when he was 30. It had just gone through multiple iterations of mutations. So getting rid of chronic Pseudomonas has never been shown. So this will be the first evidence that it might happen in CF with this drug. So here we have the log change, a log change of Pseudomonas, and the patient number on the right in a waterfall plot. What you'll see, we also looked at the ones that actually went to 0, which is substantial. So this study is only out to 3 months right now. We'll be seeing it over time. This study is an ongoing study. We'll probably go for years trying to understand what effects this drug can have on this population. And I also want to highlight one other really important study that's just begun. And this is a study we call Simplify. And again, this is run here out of the University of Washington and Seattle Children's Hospital. With the improvements of these new drugs, a lot of people started asking, do we still need to do the aggressive therapy we do with CF? I gave you that litany of therapies that we keep adding on. And some of the most onerous ones are inhaled hypertonic saline and pulmozyme, or RH DNAs, recombinant human DNAs. And so about 9 months ago, we started the planning of this major study, which is to see if we could actually take away these drugs from patients. So in study A, patients will be randomized. If they're on hypertonic saline, they'll be randomized with the potential of taking it away. And they'll take it away and we'll follow their lung function over six weeks. So our hypothesis is that withdrawing hypertonic saline is not inferior to remaining on it. And we use lung function as the measure of outcome. And then in study B, because some of these patients are on both, or some of them are just on DNAs, we actually allow the same process. You get randomized to removing your DNAs or keeping it on. And again, this is a large study, 800 patients, I think over 80 sites. And it's led out of the University of Washington. And hopefully we'll be able to tell you, can patients actually stop some of these therapies that were developed in the 1990s and early 2000s because of other advances in CF. And maybe we can determine if some can stop and some can't. So this will be a very important first step in the withdrawal of therapy in CF to see if we can simplify their lives. Now, what happened to our case? Again, this is an unusual case in his age, but I think is not an unusual case in that he had bronchiectasis, he had chronic lung infections, he had very poor lung function, and he was actually being treated as if he had non-CF bronchiectasis, where treatments are quite limited. So at this point, when I saw him in November 2006, I initiated standard CF therapy, and he had a fairly immediate increase in his lung function, up to almost 60% of predicted. Here he had a significant pulmonary exacerbation, but importantly, with the expansion of FDA approval, it turns out his gene, one of his gene mutations was actually in the expanded mutation list for Ivacafter. This gene, the gene mutation, is a gating mutation, so he has a functional channel, which could be activated by Ivacafter, and he got an immediate boost from Ivacafter. And now his lung function is almost 80% of predicted. This gentleman was very sick when we saw him. He then went on to take care of his wife, who had significant Alzheimer's, and she has subsequently died, but he is doing incredibly well, very healthy, very interactive, and having a very normal life. So with that, I want to thank you for your attention. I've tried to give enough time for questions, and I apologize if I went too fast. But I did want to close with this picture. This is a great picture that you should, if you haven't gone here, you should. This is, many people here in the Northwest love the mountains. This is in the Dolomites. And it's one of the greatest hiking areas in the world, I think. And this is a massif that we walked around and also came through this little notch up here. It really just tremendously fun. And you can always then go to a chalet and have your lunch. So hopefully when we're back to traveling, you'll be able to go there too, because it's one of the most extraordinary places in the world. I do want to acknowledge that this CF is a team sport, probably one of the greatest team sports I've ever been involved in. And the leader in our team is Moira Aiken. She leads our adult CF clinic here. She's been a great leader. She started in I think they started the clinic in 1988, I think is when the clinic began. Jay Dandekar, one of our great colleagues doing basic science in Pseudomonas. Kathy Ramos, who I noted some of her work. She's basically focused on severe CF and the transition to transplant. Pradeep Singh, he's in the Department of Medicine, my Department of Microbiology, and one of the premier pseudomonal biologists we have. And then our CF clinic and research team, because we have an incredibly high functioning team where a lot of our patients are participating in research at all times. I also want to thank the STOP team. Patrick Flume is my co-PI at the University of the Medical College of South Carolina. And then Sonia Helshi is a statistician in pediatrics, and she's one of the other PIs. And then Dutch Vandevetter is Case Western. Natalie West is at Johns Hopkins, and DB Sanders is at the University of Indiana. And then I have to give a big nod to Bonnie Ramsey. She is my mentor and still is. I meet with her once every 2 weeks, which all people should never look mentors in the eye. Keep engaged because they're wonderful. Dave Nicholls is a colleague I stole from Colorado, and it's the greatest acquisition we've had recently in our CF group. Nicole Hamlet is a statistician. She and I lead the Therapeutics Development Network together. She and I started together right after after her PhD in 1999. So been involved in CF trials since then. Margaret Rosenfeld, one of my great colleagues at Children's, who I've worked with a lot, and she was an early mentor also. And then the CF Foundation. Bob Bell was the prior president. Preston Campbell is just retired, and Mike Boyle, who came from Johns Hopkins, is the new president. And then J.P. Clancy is from Cincinnati, who now heads Therapeutics at the CF Foundation. And these are my funding sources. But with that, I'll take any questions.
Thank you so much, Dr. Goss, for some really exciting new therapies that are out there for a disease that's been around for a long time. There are definitely some questions which we have time for. One of which is a question that comes through asking about gene therapy. Has gene therapy for cystic fibrosis been abandoned? Is it too complicated or just not needed in light of these medications that seem to be so successful?
That's a great question. And gene therapy is now front and center. And it's front and center for a couple reasons. One, I believe it's $500 million effort by the CF Foundation to drive innovation in gene therapy and CF. We were one of the early gene therapy centers in CF, and it did fail early on. But now there's a big push to, one, tackle those with mutations that these drugs don't work for, but also to create what they term one-time cure. And so there are studies now, we'll be starting in the next, there's studies of delivered mRNA, and there's studies of gene therapy that are sort of working their way through the development pipeline. The advances, I think in the last 15, 20 years have probably opened the door now for gene therapy. So it is one of the biggest focuses now in CF care and CF therapy. And I didn't go into it very much because it's huge now. So.
And speaking to the scope, there's also a question of if you were aware if that gene therapy research is looking at other genes that may modulate the disease in the setting of the just vast variety of phenotypes that we can see in patients with CF.
Yeah, no one is doing that to my knowledge yet. And again, there's a whole what we call the genotyping, phenotyping approach in CF, and this has been Ron Gibson at Seattle Children's has been really central in this group, along with the folks at Johns Hopkins and UNC, identifying gene modifiers. But no one, to my knowledge, has actually thought about going in and targeting these clear gene modifiers that have been shown by these giant studies to modulate disease. And I think that's certainly an interesting and exciting area to think about, but not to my knowledge.
There's another question that asks about specifically the costs and access to these really impressive drugs and how that may impact adoption across the globe. If you could speak to that a little bit.
Yeah, that is one of the biggest challenges we have in rare diseases. And if anyone has kept their finger on the pulse of rare diseases, it's a land of exquisitely expensive drugs. And you just pick your rare disease, and the drug pricing that is actually driven worldwide by the pricing in the United States is sort of obscene. And these drugs, in the United States, we've been able to get them for everyone. It's been broadly adopted. It's important to know that this Ivacafter, Tezacafter, Ivacafter is not available in Canada. And it may not be available for years as they try to negotiate a countrywide cost for the country. And if you start to think of Eastern Europe, Albania has the highest incidence of CF in the world. It's hard to fathom how they can afford drugs like this. And I don't. There obviously has to be a period where, in the initial excitement, where these costs are handled, but then it will become a problem. And certainly in places that, particularly Eastern Europe, South America, it's even when Ivacafter rolled out, it was 15% of their patients have G551D. The cost of Ivacafter, if paid for in American dollars, was going to consume more than half the entire country's budget to care for CF with patients. So they negotiated a different price. We don't know what that price is, but I think it is going to be a barrier. It's going to have to come up. I don't know how we're going to get around that. We have a very strange system of how we price drugs in the United States.
Yeah, definitely an obstacle, not only in cystic fibrosis, unfortunately. So Let's see. There was another question that came through earlier, but actually was answered. It seems like you're addressing with the Simplify trial to see if other chronic therapies that we use in folks with cystic fibrosis, if those may or may not be needed any longer with the benefits of these new therapies. So I guess we'll have to stay tuned to see the results of that.
Yeah, we'll know soon enough. And we just enrolled our first patient in the Simplify study last week. So there's 60 patients are already enrolled in the study. So
we'll all stay tuned for that.
Yeah.
More questions coming through. Are there impacts from sustained pathology for years before adults receive this modulator therapy that we should be looking out for, such as complications from their chronic inflammation that occurred prior to their new therapy initiation?
Yeah, we don't know. There's a lot of interest in understanding introduction of these drugs into severe patients. So the most important thing to think about is liver dysfunction. This drug, particularly the new one, the breakthrough drug, is associated with abnormal liver function tests in a small subset of patients. If you have child C cirrhosis, you're not supposed to use the drug. CF liver disease is often, it's sort of considered that most people have it, but it's hiding. So that's probably the biggest worrisome thing to think about. And we may have patients who in this early honeymoon phase, we've been treating patients for about, I guess, going on a year. We may find patients that we have to stop the drug on for that reason. We're going to hopefully understand a little bit more about what this drug does to inflammation, what it does to the gut. Can it affect diabetes, for instance? There's some early data to suggest that patients who have borderline diabetes with CF can be that defect can get better when treated with these drugs. So there's a lot of interest in these sort of other side effects, and it may be that these patients there's still going to be a lot of patients who have lower airway infection. Which itself drives inflammation. So the role of anti-inflammatories will also be key. We've had a hard time, other than azithromycin and an early study, I didn't talk about prednisone, finding successful anti-inflammatories for this disorder.
Yeah, a lot to be learned still. We'll give another minute for any other questions coming through, but I want to take this moment to thank you so much for giving us a fantastic update and really taking us through the history of CF therapies and really highlighting some exciting changes. So thank you so much for being here today and all the work that you do. We really appreciate it. And it looks like all of our questions have been answered. So thank you so much for taking your time for an excellent talk. We really appreciate it. And thank you to our audience for joining in and asking wonderful questions. Hopefully we'll see you here next week for an update in inpatient medicine. So thank you, everybody, and have a fantastic Friday afternoon.
Thanks very much, everybody.
Take care.